But on the other side, the stuff that you've been doing, that you and I have been talking about for years, like this whole concept that we're moving to what's called bundled payments and MACRA and alternative payment models, there is a moral hazard when you get paid for doing things. And there's a bigger moral hazard when you make money if you fail at doing what you did in the first place. So if you go to the hospital and get paid for $20,000 for a hip replacement and then you have an infection or there's a bad outcome, hospital gets paid $40,000 5 days later for that bad outcome. And then if there's another bad outcome, they get paid $60,000. So there's like this, the runaway train is that there's a moral hazard and there's no moral imperative in healthcare. And I think that one of the things that I applaud you and what you've been doing the most is really the stuff that no one reads about. It's super wonky, but the headline is, hey, doctors and hospitals, your incomes will equal your outcomes in the future. The days of just this fee-for-service and making more money off of sick people, this sick care system, is you have to redesign, or not even redesign, you have to design a system that focuses on outcomes. And historically, doctors always knew what the best outcomes were. But the truth is that patients know what good outcomes are too. And so maybe you could talk a little bit about some of the initiatives around bundles and outcomes, because I think that's what matters to people. And as someone embedded in the healthcare system, I'm really excited about what the future holds mechanistically.
Right. Well, I think the system at various stages, depending on where you are in the country, is going through kind of this massive change management effort, massive and complex, because it really changes the way physicians, primary care and specialists work together, the way physicians and hospitals work together, the way they work with health plans. Because in effect, what we're saying is if you coordinate care, if you prevent an illness, if you keep people out of surgery, we should pay you more for those things so we don't have to pay more down the road. And I think this has sort of been a burgeoning effort for the last 7 or 8 years, but it got really serious a few years ago when we said, as Medicare, the largest payer in the country, that by the end of 2016, we were going to have more than 30% of our payments linked to a quality and a cost outcome. And the reason we did that was to signal to other commercial payers and to people practicing medicine that a tipping point might be coming. And we surpassed that hurdle. I think what we've seen in various stages, just real quickly, a few different forms of models. I think there's the surgical bundles and things of that nature that you talked about, which I think really are all about how does everybody on a care team take care of an episode better.
Yeah.
There's more population health-based models, like accountable care organizations or medical homes, which are how do you give people more up front so they stay healthier and you don't have to pay them more later. And then I think that there's an emerging set of prevention models, which are also, I think, on the scene for things like that are near and dear to your heart, like diabetes and stroke and high blood pressure and so forth.